Now, Paula, from what I understand, is from the National Cancer Action Team. She's going to certainly inform me. Information prescriptions, I think you're going to talk about. I didn't have a chance to speak to you before, but I think we'll all learn a lot from you.
The nurse or the healthcare professional will use information to support their processes. So what this is trying to do, this presentation today, really talks you through information prescriptions, how we've come to them, what they've been built on, and gives you a little bit of insight into the prototype system that we've developed to work with healthcare professionals. So a little bit of background. One of the things that the NHS was tasked with a number of years ago was to develop really adequate information, and networks in particular, cancer networks, were asked to look at the information that the trust within those networks provided, and then to start to look at how that information could be better supplied to patients, and actually making sure that that information covered all the tumor types, but also each information point or specific points along that pathway were covered, so from both screening right through to survivorship or to death. And basically that was in 2005, and what we found was when we audited this back in 2007, there was a lot of variation in actually what networks had been able to achieve. So this is just an example we found when we mapped all of the different cancer networks, and at the time we did this research that there were 30 cancer networks, there are now only 28. But what we found was there was 168 pathways that had actually been mapped. And you can see on there that of those mapped pathways, prostate accounted for 12 cancer networks, so 12 networks out of 30. So if you start to think about information giving and patients within that pathway, there were a number of networks that actually, or a number of trusts within those networks that didn't have an implemented pathway for prostate cancer that they could then share with us to put their information in this pool. So we did this exercise for all tumor types. So clearly, we're just interested today in prostate cancer. What we did with the information, when we mapped all the information, we then wanted to look at the differences in information that were available from those networks. So we basically took every piece of literature or every piece of patient information and mapped it against the key information points. And all those points are the points where it is useful for patients to receive information to support their clinical pathway. So you'll see prevention, you'll see referral, testing investigations, etc. And what we actually found was that there was a wide variation in the amount of information being given at key information points or being made available at key information points from different cancer networks. Now clearly this only covers the 12 cancer networks that actually had their information mapped, so you've still got that big variance of the others that didn't even have that information. If we look at signs and symptoms, you'll see that only 4 of the 12 cancer networks that had mapped the prostate cancer pathway had information at this key information point. And out of those 4, the information ranged between 1 information leaflet and 3 information leaflets. If you move further along the pathway to diagnosis stage, you'll see that all 12 cancer networks had information at this point, but the information varied from 1 leaflet to 14 leaflets. So you can start to get a sense of the sorts of variation that we were experiencing on the pathway. And if we're experiencing this when we're collecting it in from all the trusts in the country, then obviously from the patient's point of view, there's clearly a big difference there. So what we basically did was we presented this information to a range of key stakeholders, healthcare professionals, and basically came out with a mandate to take all the information that had been developed from all the different cancer networks, all the different trusts, and put that information into a pool and develop national information pathways. So instead of every individual trust developing their pathway and every individual cancer network pulling that together, we would develop a core national prostate cancer information pathway and for all other tumor types. And so that's what we basically did, and I think that was supported by some of the research that we found from the National Survey Programme. So in 2000 we found that there was a wide variation in the experience of men with prostate cancer in terms of their patient information experience, and that was worse than people than any other tumour type, but also there were wide variations in that experience. If you lived in London, it was more heightened, and also if you're from an African or Caribbean or BME, Black and Minority Ethnic Community. There was another survey that was done in 2004 by the National Audit Office, which repeated the 2000 survey, but basically on a smaller scale. And although there was some improvements in that experience of prostate cancer patients, they were still coming out as having a worse information experience and patient experience than other tumour types. We have just completed the new National Cancer Patient Survey. It's being produced at this moment in time. It's being analysed. But actually in that survey, we can say that the gap has been reduced for prostate cancer patients, and so we now can see that prostate cancer patients are reporting similar experiences to other tumour types. I think a lot of that is really down to the fact that we now have the IOG's now come out with improved outcomes guidance. We now have many more CNSs than we did in the previous 2000 survey, which absolutely helps in terms of patient information. What we did was, in terms of taking all of those things around the experience of patients and trying to understand their information needs, we wanted to test out whether producing these national pathways would actually make a difference to patients, and whether also healthcare professionals could use them in clinical settings. So we set about piloting patient information pathways and also piloting a prototype system that those information pathways sat on. And we did that with 11 networks, and those are the cancer networks on the screen. We produced a number of tools to support them when they were in their pilot phase. So as well as having an electronic system where all the pathways sat, we also produced some paper information prescriptions, very similar to a normal drug prescription, but actually this is about patient information. And the idea was that the healthcare professional would use this prescription within their consultation to support information giving. So some of the issues about people not being necessarily proactive in asking for information, this is there as an aid manual for the healthcare professional to go through some of the information that was available, and hopefully people within that then would be more inclined to take information. So this was a prescription for our general information. We had one for palliative care, and we had them for each tumour-specific cancer. So this is the prostate cancer one, but equally we also had a consultation discussion record that actually had a diagram of the prostate on there that the consultant could use to describe what was going to happen to the patient in their next visit to the hospital. So I wanted to share with you what the information prototype looked like. So the idea was that we developed this system. The system was there to house all of the information that was placed on the National Information Pathway. And I should say that the information on the information pathways was done through a bottom-up approach. So we basically gathered all the information that was currently available, went through quite a robust quality assurance process, and then placed all that information on a draft pathway, sent that out for consultation, and then came up with an information pathway. We then developed a system to put that information into, which the healthcare professional could use in their consultation with the patient to give them information at different points of the patient journey. So as I said, this is a prototype, and this has been used in probably about 130, 140 sites already across the country, so very well tested. So basically you go onto this system, you'd click on prostate, and then you'd hit the next button. It then gives you a number of key information points of which you can select, which will come into subcategories. So in this instance, show some diagnosis and treatments. Once you've pressed the next button, it then takes you to the information that's available. So you'll see that the information is broken into subcategories. We put at the side of it where that information is from. So if it's from the prostate cancer charity, it's PCC. If it's cancer backup, etc. So basically, the healthcare professional can review the information at that point, but they can also just tick the boxes that is relevant to the patient. Obviously, this is in consultation with the patient. We're not suggesting that healthcare professionals sit there and tick all the boxes. It's about having a dialogue with the patient. It's about supporting that consultation process. If the patient doesn't want information, then they can tick declined. And I think what's been useful for healthcare professionals is it gives a record of what's been offered, even if the patient chooses to then not take the information. So once they've clicked on the ones that they want, the prototype system, we designed this into the system to automatically take them to an all-cancer section. And the reason we did that is because we know when we asked patients about information, the information that they didn't usually get offered was information on the supportive aspects of cancer. So how do you break the news to your children or your family? What are some of the issues of dealing with your emotions? So things about asking about what happens, can I have sex after this operation? Those sorts of things that patients don't really want to necessarily ask their healthcare professional. So we made the system take them there automatically so that it would prompt the healthcare professional to ask the patient whether they did want any information out of this section. And basically, once you've clicked on all the things, it takes you to a confirm page and shows you the leaflets that are in the section that you've chosen. And then it prints them all off with a summary at the front of that for the patient to take away with them, and a summary that also goes into the patient folder or the patient notes. And that was our prototype, and really it was trying to have a system that would support healthcare professionals, but support them to give information in a supported way that is also auditable and measurable across the country. So clearly this was a big change in the way that people use their information, and a big change in the way that healthcare professionals get delivered information to patients. So we wanted to make sure that we got it right. So we had a number of listening events to try and get feedback from those healthcare professionals that had used the system and been piloting it. We had 5 regional events. We covered about 200 people. We then did exit interviews and asked them for their comments. And basically there was a number of requests. They wanted the new system to have even more functionality on it in order for them to use it in a busy practice. They wanted assurances on where the information had come from and the quality of that information. And they also wanted to know how we were going to fill gaps. So if they'd come up with a gap in terms of there wasn't any information on nutrition, or there was some comorbidities that we weren't covering, then they wanted to understand how we were going to do that. They also wanted a local aspect to that prescription. So if it was St Thomas's, they wanted to have something on there that said St Thomas's on there. They wanted information that had been developed by the NHS to also be part of that information pathway. At the moment, the information pathways are made up of information from national charities. So all the different charities that you can think of, we have a relationship with them, and their information is on the pathway. And they wanted to be able to personalise it, so they wanted to be able to say that this is Mrs. X or Mr. X's prescription, and be able to write on the prescription what they felt that was important to both the patient, but also messages back to the patient. They wanted it more flexibly to be delivered, so it to be not only used within the hospital context, but also could libraries have a part in playing giving information prescriptions, where there are other people that could take part in the delivery the delivery of that prescription. They also wanted more training, and they wanted to work with us more in terms of a more direct approach from us to each individual trust in the country. So basically, what we did was we've developed a new national implementation programme that will kick off later this year. We've had a number of events. I've been going around the country for the last previous 2 months, and I've saw about 1,000 healthcare professionals across 27 events over the country, just really saying that this is what we're doing, this is what the new system looks like, any questions, and this is how we're going to support you. So we've developed an e-learning tool, we've developed a train the trainer course, and we also have a trust-based training program that will kick in, and an MDT-based training program that will kick in later in the year. To support the implementation, and one of the things that people said to us was, if you want this to work, if you really truly want information prescriptions to be delivered to every cancer patient, then you're going to have to come and sit in my NHS Trust. You're going to have to sit with us for at least 6 months to work this through our MDTs, to work this through our consultants, to work this through and get it embedded into what we do. So that's what we've done. We are offering to every trust in the country a dedicated facilitator to sit in their trust with them, to support them to embed information prescriptions, and we're doing that over a 2-year period. We start with 6 months and we have 15 beacon sites, and then we move to 6 individual waves over a 2-year period, and that facilitator will be in that trust for a 4-month period. So it starts with 6 months and goes to 4 months until we reach saturation of every trust in the country. So what does all this mean, other than lots of work and lots of energy? I think it ultimately means that we'll have information in this country for cancer patients in one place, which covers all cancer charities, and the content has been written in terms of good practice from NHS trusts. It will be electronically available both to patients and to healthcare professionals on a platform that will be available to everybody. It will be updated material that will be reviewed on a 2-yearly basis. There are options to have additional prescription pads, so to have it in paper versions if organisations so choose. But it also means there'll be a generic pathway that can support people through all aspects of their cancer that will be available and updated to healthcare staff and to patients. And we also have downloadable templates so people can use it in a variety of ways. So what are we doing next? We are moving to a new system, so we're taking all the learning from the prototype that I've just showed you, and we're moving to a new system on NHS Choices, and that system will be called the Information Prescription Service. It has lots more functionality on that new service, and you can interrogate very small pieces of text, drag and drop things in, and make a very bespoke prescription for that individual patient. We will start to evaluate the implementation later on next year, and as I said earlier, we'll be looking to roll out this whole programme over the next 2 years, starting in the next 2 or 3 months.
Well, thank you very much for it. Very impressive, very laudable. I've certainly learned something. Let's see from a show of hands how many other people in the room were aware that this was going on. So, well, you've done it. That's what I was going to challenge you. You're going to put someone in every trust in the country for 6 months.
Well, 6 months is the beacon sites for 6 months. So we'll have 15 beacons, and we've already appointed those beacons, and the other 150 trusts will have 4 months dedicated support.
So any trust can we apply, or do they just arrive?
Yes, no. Every trust has already had the opportunity to apply. We had 30 trusts.
Missed it.
I
cancelled it.
Right. What trust are you from?
Sheffield.
Oh,
Sheffield, that's up north.
Yeah, no, I know. I'm actually from the West Midlands, so I know where Sheffield is. No, everybody's applied. So we basically, whether you have or not, there's 60 trusts in the country that haven't applied, so you may be one of those 60. We are chasing those. But basically, we've had 111 applications for the support for the waves, and we've allocated 15 to beacon status, and they were published in a newsletter a couple of weeks ago, and then the other 80 or so trusts will go into subsequent waves.
So there'll be a single individual for the trust for all disease areas? Disease groups?
Yes, yes.
Right, okay.
Yes, so
what will these people be? They'll be...
They're basically facilitators, so the idea is that
their background will be...
Well, most of the backgrounds are nurses. We've just recruited them, our recruitment finished Tuesday. So it's all hot off the press.
It is, isn't it? Job creation scheme,
absolutely.
isn't it?
What I should have said is, because clearly we're in an economic...
yes, that's what surprised us.
Absolutely, and my team's just increased by 17 new staff. However, I need to qualify that by saying we have been, this programme has been part funded by Macmillan Cancer Support, who have given us an awful lot of money to pay for the facilitators. So it's actually not NHS money, because clearly in this environment we wouldn't get that amount of staff, but we have financial support from Macmillan and Cancer Research UK.
Well, very impressive, well done. Questions? Questions for Paula, anyone? Yes, please. Tell us who you are, where you're from.
Hi, my name is Julie Bassnett and I'm from UCLH. I just wanted to clarify, because this is something new to me. Will this mean that we bin all our current patient information leaflets that we would give out? So whether you're in Penzance or Glasgow, you're basically getting the same information?
No, you don't need to bin it. UCLH actually was one of our very first pilots.
Just 6 weeks.
Oh right, okay. but you were a gynecological pilot, so it was used there. No, basically what we've been saying to organisations is that there's a difference between national information and very locally developed information. So there are trusts that have information about where the pathology labs are, who the MDTs are, what they do specifically in that organisation. And clearly that is absolutely still relevant and needs to be still developed, but developed in robust ways. What the system does is allow you to use basically a basic suite of information and to add to it with your own local information. And in time, you will be able to upload all of your local content, should you wish as a trust, onto this new system, so you're using one operating framework.
So what will happen to the Prostate Cancer Charity Toolkit?
I think we have it.
It's part of it.
It's part of it,
that's
yes.
Great. Questions? Yes?
And I'm actually currently using the system, so I'm just interested in your comments, because although there's new CNSs available, there's still not enough of us. And when you can see that prescription pad there, by the time I've gone through that with a new diagnosis, they've already seen 2 more patients that I haven't caught up with, because you're going through that pad, you have to go through to the print office and get the printed copies, give everything to the one patient. So it is, I find, very time consuming.
Yes. No, absolutely. And I did have a video which I wanted to, I had some urology clinics on there that were talking about that, but then how they'd actually combated that. What we are actually doing is we are moving to the new system, which, so the one that I've showed you and the one that you'll be using is the prototype system. The NHS Choices one is actually much faster. It's a fast, because it's basically it's NHS Choices and it's on a better platform than we did the prototype. The other thing was the paper prescriptions that I showed you that people were using in the pilots will go. What it will be replaced with is that the Choices system allows you to pull off at any time a blank version of what's on the system. And some of the issues that we had with the prototype, where when you printed it came out in different formats, so if it was an A3, it would turn over and it might be on the back of another sheet. All those go with the new system, because actually it puts it all into a PDF and it scans it all onto one prescription. So some of those issues that we had with the prototype have been resolved moving forward, which is why we needed to pilot it so extensively. So thank you.
I just take paper version, paper booklets given.
Right. and it's interesting, because when we did the sort of around the country jaunt that I went to Sheffield. When I went around the punctually, one of the big issues were about time, and on the new system we actually have favourites. So it's a bit like Google. You can actually create a template that is, so you might have specific local leaflets that you already want to use that you put in there. You might have Mrs. X or Mistress, and you've written that in already, and basically you can save different types. So you might save a diagnostic one, you may save a treatment one, and all you're doing then is adding to it. So it's much, much faster and taking account of those issues.
Was another hand up? Yes?
Hi, I'm Sally from Cambridge. We're using the system at the moment, and I think it's an excellent way of getting information to patients. We don't have printing facilities in clinic, and that's one issue, so it's all done retrospectively. And also I worry about how the documents actually look to patients. They don't look very appealing. When you look at the toolkit, it's very professionally produced, and then you're sending a 200-page black and white document.
Oh, I hope not.
If you're sending patients all of the information for all of the treatments, it's a good 200-page document.
There's a couple of nodding heads.
Right.
Very advertising and appealing.
Okay. I mean, there's two things
Thank
in
you.
there. One of the things is, if there's a booklet that actually we wouldn't want you to print a whole booklet out. So if there's a booklet, we'd just expect you to take a paper booklet, give them the hard copy booklet if you had that, if you already had a copy of that. The other thing that we know has been an issue, and we've rectified it, hopefully in the new system, is that you can actually email this prescription to the person now. So instead of printing it all out, you can email it over to them. You can also attach videos, so things like the prostate decision aid DVD and all of that can actually all go via email on the prescription. So we have, we hope we've addressed some of those issues, but I think we have been saying that if there is a big booklet, like some of the cancer backup booklets, 60 pages long, we would never expect you to print it. If you've got a hard copy version, get them the hard copy version.
Okay, last question.
Hi, I'm Lucy from Colchester. We've actually been part of the pilot and also, luckily, part of one of the beacon sites. We have lots of different issues that have come up over the pilot side of things, and they've been discussed during in the room. A couple of questions I just wanted to ask was, we were actually told that we're not to give out booklets because they might have been on our shelves for ages and the review date might be wrong. Well, we're very, very on top of our review dates within our hospital, and took it slightly as a negative point that that's what we would be doing. We would like to be able to give out booklets because we completely agree with the fact that printing off huge documents that actually are produced beautifully by the Prostate Cancer Charity would be a retrograde step. And the other thing is that within our financial situation at the moment, there's nothing looking at the cost of cartridges and the amount of paperwork that we've been printing out and the financial cost for the trust. I have trouble getting my stationery signed off for the cartridges I use at present, let alone the information that went to this way. It's much cheaper to do it via printers and via charities.
Nodding heads.
Yeah, no. I mean, I'm not quite sure where the don't print the leaflet out.
Well, that's great.
Because that's yeah, no, absolutely. I mean, and clearly there is an issue about it being the right version, because we know when we collected things in from the trust, we got things that were like 4 or 5 years old. So if you're on top of it, fantastic. But yeah, we would always say, and I think throughout all of the visits I've done to different sites, we've said, give out booklets if you have it and it's up to date.
Okay, I am going to draw that session to all. It's been fascinating. I've certainly learned something. Thank you very much. I've allowed it to run on because I think it is an important thing, and it's something which perhaps if we were all back here next year and talking, this would be something that would be in our hospitals.